Hello, my name is Daniel. I'm a registered respiratory therapist at an acute care hospital, but I also work here at Hayek Medical as a clinical educator. I let you know it's a great honor of mine to work here at Hayek. I really enjoy being able to educate physicians and respiratory therapists and you guys, the patients and consumers. At Hayek Medical, we run what's called continuing education credits. Every respiratory therapist in the United States needs to have what's called CEUs to keep our medical license. We are an approved educator for CEUs. We do them for free. So if there's any RTs online here, we do CEUs for free. But it's part of us getting to know you, our constituents, but also because we really value, and I love being an RT, the RT trade. So our CEUs are about various topics on the respiratory continuum, teaching people about from acute care all the way down to how the heart works. We have a lot of good stuff to teach. So please join us if you're an RT. But today we're going to talk about early intervention and patient advocacy. For our patient event, what we're trying to do is we're trying to educate patients and you guys, consumers, because empowered consumers make really good decisions. And at Hayek, we're not saying that, well, we're going to educate you and you're going to automatically choose Hayek. We as RTs and as professionals of Hayek feel that patients who are empowered to make choices can make educated ones. And we have the knowledge, so it really is a responsibility of us to teach it. So it's free. We're glad you could join us. We are hoping that with every one of these that we do, we get more people and we get more questions. Okay, let's dive in this early intervention and patient advocacy. So today's discussion, what we do and who we are, respiratory issues. Sadly, we're here because of respiratory issues. Like I have a job because people can't breathe or are dying. I'm always mindful of how bad of a day I think I'm having when I compare it to my patient's worst day. Okay. But we're here to help. We're here to educate. We're here to empower. Speaking of the power of early intervention, early adoption is kind of bringing something into the mind, is absorbing a concept. And the power of early intervention is then acting on that concept or starting at the first glimpse that intervention can be needed. Okay. And none of this goes off at all without the need for advocacy. As an RT, I advocate for my patients all the time in the hospital, whether they're conscious or not. I advocate here for Hayek Medical. I advocate for patients. There are patients who I talk to here at Hayek Medical. They're our customers, our patients, and we share information, advocacy. They teach me things, and the things that I learn from them allow me then to turn around and become an advocate for other people and other patients. Okay, so it's a great honor to work here and work with the crowd that I work with. Who are we? What do we do? Well, I said earlier, we're educators, we're respiratory therapists. We have physicians, two great physicians that work with us, really great guys. We're dads and moms, we're aunts and uncles. We're real people here, right? We're a manufacturer and we're innovators in ventilation. What I mean by innovators is, what do we do? Well, we have the Biphasic Cuirass ventilator. Now, the cuirass in medieval times was armor that was covered the chest. The cuirass, it protected the chest. Here, the cuirass goes over the chest and it lifts up the chest in a normal way to create normal breathing patterns that are enhanced to help people with respiratory issues. Unlike using a mask, which creates a pounding positive pressure, this creates a normal negative pressure. Because our lungs use negative pressure, our diaphragms go down and that pulls air in, right? So our lungs use negative pressure to expand and to fill themselves. And that's what we do here at Hayek. We mimic what the natural body does because it's what's best for the body, also helps ventilate the most efficient way. Biphasic Cuirass Ventilation, affectionately known as BCV, works by facilitating, here goes, the normal function of the lungs. When we inhale naturally, our respiratory muscles contract, causing our diaphragm to flatten and our chest wall to expand, pulling air into our lungs. Now, air is naturally pulled into the lungs by the negative downward motion of the diaphragm. With positive pressure, it is pushed into the lungs. And it can have damaging effects. Of course, when you push air into the lungs, it can have damaging effects. When you pull it in naturally with negative pressure ventilation, there isn't really an issue pulling the air in with negative pressure ventilation. Everything has its drawbacks, of course, but negative pressure ventilation with BCV is the most like normal ventilatory style you can use. Okay. BCV mimics the process of non-invasive form of ventilation, assists those either chronic or acute respiratory needs. So it mimics the process of natural respiration in a non-invasive form. Okay. It offers comfortable, mask-free, non-invasive respiratory support for adults and pediatric patients. The cuirass goes over the chest and creates a negative pressure, which we breathe normally. So negative is normal. It's kind of a theme. This is the way it kind of looks. This is just an illustration from one of our guidebooks. The cuirass goes over the chest and creates a negative pressure atmosphere, which helps the diaphragm drop down, lifts the intercostals, and creates an open airway. Okay. In a medical term, we call that patent. Patent means open, so it creates an open patent airway. Okay, here's a cool diagram that I like. I'm going to show this to you. We show this a lot. The diaphragm drops down. You see that? It causes the chest to expand. It goes back up, and we exhale. That normal motion is enhanced with BCV and is not really supported with positive pressure ventilation, which pushes air in through a mask. But the chest cuirass lifts those rib muscles up and allows it to breathe normally. So that chest cuirass moves the chest up and down. And as it moves up and down with negative pressure, it allows to have much more negative motion, which is much more normal motion. Okay? Awesome. So respiratory issues. Sadly, we know there are respiratory issues. Individuals with neuromuscular disease may experience respiratory problems due to weakened muscles involved in breathing. This can lead to difficulties in coughing, clearing airways, and maintaining proper ventilation. Okay? Weakened diaphragm and intercostal muscles, basically. And those are the muscles that are, the diaphragm is this muscle down here, the big muscles going up and down, and the intercostals are the ones along the ribs. Okay? Now, if started as soon as possible, NIV, non-invasive, that means no tube in the throat and no trach in the neck, okay? If started as soon as possible, one study found that patients who started NIV at home had an overall survival of 6.5 years, okay? So they expanded their life by 6.5 years, okay? That was the average. So that means that a portion are less than, but that also means a portion are more than. Okay, 85.9% at the first year, 68.7%, almost 70%, and almost 60% at 5 years. Okay, as you get NIV on sooner, you can basically put a parachute on your respiratory issues. You know, the respiratory issues may not advance as quickly because you're able to begin to help them strengthen, offload, and to support them sooner in the continuum of care than later in the continuum of care, okay? Stable, which means staying the same, and progressive, which means obviously changing, neuromuscular disease. NIV improves survival compared to the controls, the patients without or who are intolerant. Now, I used to work at an ALS clinic at a major hospital in Philadelphia, and we found that 50% of our non-invasive ventilator failures was because of mask interface. So if we're not applying the mask, then what is the failure rate going to be? We're not sure, but I know this much. The cuirass does mimic much more normal breathing, gives a fuller, deeper breath, and can also, while on the chest, apply assisted cough and high frequency chest wall oscillation, which not only clears the airway of mucus, but actually helps recruit tissue by pulling it open gradually over time. You now don't have to worry about the advanced decline, according to the study here, okay? And notice that NIV improves the quality of life and symptoms, particularly orthopnea and sleep disturbances, okay? So orthopnea is a fancy term for I can't breathe when I'm laying down. It's one of the earlier signs in some things where patients lay down and their respiratory parameters decline. because gravity against their chest and weakened muscles, they'll notice, hey, I can only breathe when I'm sitting up in a recliner. It's one of the earlier signs in many disease states. Some of them, it's a later sign in disease states, COPD, cystic, congestive heart failure has a problem with that. Patients with cystic fibrosis have sometimes complained to me that, they know they need their clearance when they lay down, they can't breathe. But gravity pushes the heart down and pushes all that stuff to the back of the, and you have to breathe against that, work against that. Neuromuscular conditions oftentimes experience orthopnea, which means then you can't sleep. You're breathing too shallowly, which means you get hypercapnia, which is too much CO2 in your body because you can't breathe deeply enough to expel it. Okay, but we know that this little chart on the right showing the decline rate of people on NIV and off, and I'm going to enlarge it for you. Look at this. This is actually tremendous information, right? The light blue line is those on non-invasive, as charted throughout this thing here. Okay. Look at the decline rate. It's much faster, much steeper on the dark blue on the left, much steeper. And the total overall days reach somewhere about 300. Where you look at the light blue, it's about 700. Let's just say that 300, 700, it's pretty accurate. I believe that's pretty close to the study. That means about 1 year to about 2 years. Okay. So, and the decline is much faster. Okay. Now, the thing is, early intervention is the best key for many things. Not all things, but many things. For respiratory, it is. And one of the frustrations I had as an RT in the clinic, and as an RT on the floor at the hospital, is why can't we get certain things to patients as soon as we need them? At Hayek, we have some brilliant, wonderful people who work in the back office. Our COO is really brilliant. And the guy I work for, Mr. Mefford, is just a brilliant man. They've looked at how can we get this device sooner to people? What, insurance standards can we follow so that patients can get the equipment sooner and not have to jump through hoops? And I just want to show you two things that we saw in these clinics that were just infuriating sometimes. So the one is what you have to do with Duchenne's to get a thing with the mask, the BiPAP, to get the non-invasive with the mask. It looks like algebra, right? I don't know if you love algebra. I've never met too many people go, you know what, I love algebra. I actually haven't really met anyone who says that. I mean, we use it, but these standards right here show us what has to happen in order for a patient to qualify for non-invasive with the mask. Non-invasive with the mask, right? It's rough, and it was hard as an RT. Sometimes we'd send people running down the hall, walk up the stairs. Okay, walk upstairs, come back upstairs, come back. Let's try you out again. Okay, walk around the building. Okay, I'll go over there and do some just to get them to qualify because you knew they needed it. You knew by the next time they came back 30 days from now, their vital capacity, that's a test where you blow into a tube and it tells you 100 is normal, 75 is the fringe of okay, and below 75 is not good. Okay, so patients benefited the sooner you got them on, right? Closer to 100 mark, right? Okay. The lower you go on this chain, the faster you decline. All right. So look at this standards. It's confusing. It's frustrating. And it really is hard to do early intervention when you have to jump through so many hoops, because when you're super sick, your rate of decline is faster. This is one that was from ventilation for non-invasive ventilation for ALS. It shows you the complex theatrics you kind of have to go through to get the equipment you need. Now, I loved working with different home care companies who were so good at helping the physician prescribe it. I've saved many lives with mask NIV. I've saved many lives with mask NIV. I pick on it only because I can, but I've saved many lives with mask NIV. And I still feel that any type of non-invasive ventilation should not be this hard to obtain. If your preference is to wear a mask, it shouldn't be this hard to obtain. And the reason I'm sharing this with you is because if you're not going to choose Hayek, okay, maybe don't choose us, at least know what's your battle. Say, hey, I learned in this training, I need to get this on as soon as possible. What can I do to get this on my patient, on my brother, on my sister, okay? fight to get whatever device you need on the patient as soon as they can, as soon as it can be helpful. Okay. I'm not saying with your FVC 100%, you start sleeping with the BiPAP on at night, but there are signs that you'll see that once early intervention should be enacted, it's going to have a great effect. Okay. It's going to have a better, more positive effect. The sooner the start, the more likely one is able to preserve vital lung function in the most important area. So, as lung function deteriorates, other things dependent upon full lungs also fall apart. Makes sense, right? So, FRC, our functional residual capacity, is basically what our lungs look like when we inhale and we exhale to rest. That volume right there is our functional residual capacity. It's what we have to use until our next breath. So with good functional residual capacity, you can swallow. You got to hold your breath to swallow, and you need the change in air pressure and here to swallow. If that change in air pressure isn't there, your swallow's weak. Sometimes that's one of the first things people notice with a diminished FRC. It's like, I'm having a hard time swallowing all of a sudden. Sometimes that has to do with the muscles around your lungs creating a diminished ability to swallow. As a swallow may disappear, sometimes you'll notice, now I'm clearing my throat a lot. I can't cough. My cough's really weak. Those are two really early signs, bad signs, we'll say. They're just two definitive signs that maybe there's something with the airway, with the functional residual capacity. Why? Don't know. Okay. We don't know until we actually test and find out and run diagnostics and find out what's going on. Okay. Generally, the loss in volume will create a loss in pressure. The loss in pressure will decrease the ability to swallow and decrease the ability to cough, because cough likes big filled lungs so they can cough. Wimpy filled lungs don't cough so hard. Okay. As that goes further down this chain, as the volumes decrease, your ventilation can become impaired. And ventilation is this. Breathe in, right there. That breathing out, that's ventilation. I've now gotten rid of CO2. That's the most important function of your lungs, because if you don't get rid of CO2, you cannot bring more oxygen in. It is vitally important to be able to exhale the CO2 in order to bring oxygen in. Okay? Oxygenation, the better your FRC, the fuller your FRC, the better you're able to oxygenate as well. And speech becomes a problem. Speech can become a problem because you can be so short of breath that you can't speak. And I've seen patients, sadly, that are this short of breath. Now, all these symptoms start piling up. You end up in the hospital, right? And hospitals are very expensive, right? They're an expensive healthcare setting. It's an important goal of home care. So if you had early intervention, home care established at this point, someone would be saying, you know what, Jim, your speech is off, or your cough is weak. Let's hit you with the high frequency chest wall oscillation. Let's use continuous negative a little bit longer during the day. They found that interventional studies found that those who have home care regimens at home have a reduced total days when they go back to the hospital. So in a scenario, if you go back to the hospital with a home care regime in place, it's found that you get home sooner because you're better conditioned and you have a better plan in place. But studies have pointed that out, and it's kind of like no duh, Dan, but it really is something if you stop and think about it. If you get that early intervention, you get that home care set in place, you get the device in that you need, you get the RT support now, and I'm going to show you something that is it blew my mind. I use this in one of my continuing education programs for RTs, but this will be interesting, something for you guys to see. Starting in home allows home intervention, which shows tremendous results. This comes from a pretty broad study, broad by meaning there was a lot of patients involved, that showed that if there was an RT in the home 30, 60, and 90 days, like in periodic checkups, and not just coming to your house and watching Netflix and eating, Tostitos, but actually giving you advice, interacting with you, interfacing with you, helping you create plans, the results were incredible. They showed that 23% in the first 30 days of leaving the hospital, going back home, basically, 1 in 4 were readmitted without an RT. Okay. 60 days later, it became 1 in 3, 34%. And this is amazing and sad at the same time. If there was no RT in the home at 90 days or no intervention or plan regarding RTs, calling, RTs following up, just a plan with RTs ensuring your home care regime was followed and tweaked as needed, 44%, basically half the patients by 90 days went back. Look at this on the right side though. 12, 12, and 13%. This is how you know I didn't make this up. 13, no one makes up 13%, right? I had to make it 15, to make it believable. But 13% during that thing was 13%. So it is significant that it only went up 1% from 60 to 90 days, but it's significant how much different it makes to have this type of intervention in your home, okay? And having someone watch your back, give you good advice, call you every 20 days and say, hey, Jim, are you out of supplies? What are you doing? What's your algorithm look like? How long are you using BCV? Are you using it at night? Are you using the assisted cough mode? Are you using the high frequency chest wall oscillation? Like, as you start making those tweaks, that's what keeps you out of the hospital, okay? That type of called peer-to-peer, meaning we're talking to each other, peer-to-peer advocacy. I'm getting you to do things, okay? But that advocacy also needs to extend outside the home, and it needs to go out into the world. So the need for advocacy is really this. Studies support the benefits of in-home patient medical advocacy, okay? Keeping patients at home, educating them well, and letting them begin to advocate for themselves. Okay, in key areas. So the first key area is improves healthcare access and outcomes. Access meaning patient advocates help patients navigate the healthcare system, improving access to necessary services. This support can lead to better communication between patients and healthcare providers. So this conference, like right here, this patient event, someone might have led you here. Our goal is to empower you to start thinking about being an advocate for yourself or for someone else, right? This is a scenario, if you start interfacing with our company, we're happy to communicate with you about our device, about respiratory as a whole, okay? We're happy to advocate for you if you're one of our patients, right? It means us interfacing with you and your physician and us making sure that you get what you need. And that's why having an advocate along kind of helps create that communication and access, okay? Empowered patients often experience better healthcare outcomes. So empowered either by Daniel, I'm going to call your doctor with you and I'm going to answer the questions for you because you don't know enough about this device and I don't know enough about you. So together we make a great team. That helps. Also, it helps that if you and I create a rapport, you end up adhering to treatment better with this type of advocacy and follow-up. 2, enhanced patient-centered care. Patient-centered care is care that reflects around the patient's actual specific needs. Okay, for example, my buddy Ron broke his arms and we give him crutches. Well, that's not going to help him. That's not patient-centered care. They're like, well, you have broken arms, you need some type of assistive device. This is an assistive device. Take this. That doesn't work, okay? The patient-centered care he needs is arm-related, not leg-related, right? We all know that, okay? I make a joke of it, but patient-centered care can be as wildly, unrealistic as that, or it can be like what I've seen a lot is patients go to the doctor, they're short of breath because their FRC is low, and they get an inhaler. And I see this with my ALS patients a lot. I'm like, it's not going to help. The inhaler is not going to increase their FRC because that's not their problem. That's not patient-centered care. Okay, patient-centered care is saying, I want to expand my lungs. I also need an assisted cough device. I also need high-frequency chest wall oscillation. I saw this device. I went to one of their patient conferences, and I really think, given what I have, this is the most patient-centered care I can get, is targeting these 3 areas of my problems. My orthopnea is a problem. I can't breathe when I lay flat. Okay, patient-centered care involves around your actual conditions and symptoms you're experiencing, okay? And so it leads to higher satisfaction to have someone who's really focused on your patient-centered care. This is particularly effective when advocates manage a complex system with their patients. So patient-centered care, then, what they're saying is, yes, I now know I need Hayek BCV because I want to increase my functional residual capacity because I've had all these problems that Danielle was talking about. Now I need to engage with my physician about this, right? And say, no, I know you're going to prescribe a mask, but I want to try this first. This is how this can be patient-centered care for me, and not just, run of the mill, toss out a script for whatever device is in that week. This is how I think I can have patient-centered care, because that revolves around your specific needs as a patient. Okay, patient-centered care, and that's a big one for advocacy. The need support in overcoming barriers. Okay, so now you have your Biphasic Cuirass ventilator. You're using it great. You feel great. Your swallows may be improved. Your coughing is definitely improved, right? But now you need more supplies. Or say your doctor scripted it and you didn't get it, and you live on the 20th floor. Advocacy helps address overcoming barriers. So what I mean by that is, like, someone calls and say, hey, you know what? They need more supplies. Okay, we'll send them to you. You call one of the lovely people in our back office, and for me, whenever I call them, they always basically help me overcome my barriers, and they advocate for me to get what I need. But advocates can help overcome barriers that once you're kind of starting to get the care you need, sometimes there's barriers in the way, and advocacy can help with that. Help patients communicate more effectively with their healthcare providers, ensuring that their preferences, okay, are heard and addressed. Okay, so before it was patient-centered care based on my actual needs. Now this is based on my preference. Like, okay, I really would like to get my products delivered to my home because I'm wheelchair bound, right? That's advocates can help you overcome that barrier. Don't take all that on, but also someone who prescribes something for you then isn't going to deliver the stuff to your house. Advocates, a durable medical DME can be an advocate for a patient, bringing the equipment to their house, setting it up, talking them through the process. Okay, very important step. To me, this is the most important step, and what I was hoping, and what everyone else here at Hayek was hoping. We were hoping to empower you to be self-advocates. So this educational course is one of those things where I want to whet your appetite to be your own self-advocate. And empowerment through advocacy helps patients take control of their health and well-being. So what that says is this: okay, my advocate helped me get the BCV. Ron from Hayek came and set me up, right? So I overcame those barriers. Now it's patient-centered care because I really need that high-frequency chest wall oscillation to help me cough. But now I'm seeing I want to be more actively engaged. I want to learn more about this device. I want to see what I can do differently with it. I want to see how I can titrate and increase. And okay, empowerment helps patients take control. Now that I have this on, I want to start eating better too. I want to start sleeping better. I want to start looking at the other areas that combine in my total health picture. Okay. Educated and empowered patients are more likely to engage actively in their care. Okay. And leading to better healthcare behaviors and outcomes. That's the truth. Okay. We like to see that. Empowerment includes making positive lifestyle changes and adhering to medical advice more consistently. Okay. Here's a great example of what I'm going to talk about in the next kind of thing, is a disempowerment experience. We can experience disempowering experiences. You bring the brochures to the doctor from Hayek Medical, and they're like, you know what? I'm not going to read those, right? And we'll talk about that in a minute. But that can have a disempowering experience for you because it takes the power away from your decision making and your autonomy, and then places it in nobody's hands at that point. Sophie Savage, author of a great book, The Cancer Whisperer and Cancer Thriver, cautions against giving up hope. Sophie herself was given a terminal diagnosis in 2013. Sophie recounts this disempowering experience. To me, at first encounter with a new doctor who had read my file, "You're difficult," to which I replied, "No, I'm Sophie," and I would extend my hand. So what was she saying? She was saying that she really had to basically proactively overcome these disempowering scenarios. I have been inadvertently disempowering. Well, that may not work, and isn't. And I seek every day to be the most empowering RT I can be, but no one's perfect in this world. But some people, through either their own ignorance or their own practice, or this is not the way we do it, or we've always done it this way, or that device only works on children, they can be very disempowering. And the problem with being disempowering as a professional, as an entity, is that you don't always get your best out of your patient, and the patient then feels unheard. But also, some medical equipment, pharmaceuticals, treatments, even like homeopathic treatments, things sometimes disappear off that patient's choices list, and they shouldn't. Empowered patients should be able to make decisions. And so one of the things that I see as a person who works here and as a RT in hospitals, I see very often disempowering medical interactions. I wanted to bring them up. I wanted to bring that up in this thing, why advocacy is so important. Dismissive. I've had patients who have taken literature to their doctor, and the doctor's been like, I'm not reading that. I'm not. I know you did your research. I'm not reading that. Here's what I'm going to prescribe this. You don't get a choice. And that's very disempowering. It takes the power out of the patient's hands to even have a conversation. An intelligent conversation that says, you know what, here's why I don't like that. Okay. Here's the 5 reasons. Okay. Hayek may not be everyone's cup of tea, but we know that people out there we can help. We actually tremendously are helpful. Okay. Lack of empathy. Sometimes, someone's been working a long time, working 16-hour shifts, and a patient comes to you and they're like, says this stuff to you, and you're like, I understand. This stuff never works. I've been doing this for 25 years and I've seen 5 people survive. That's a lack of empathy, because each person, it's their first time stepping up to the plate in the big game. And I'm very cognizant of that in hospital. When I talk to patients, families who are crying over someone on a ventilator, I don't look at it like, hey, this is my 10th ventilator today. I look at it like, this is grandpa, this is dad. And really have learned in my career to check myself and to be empathetic in every situation, that this is the first time or the second time, or it's very new to the people going through this. And that lack of empathy creates a disempowering exchange. And ignoring evidence. That's one of the ones I think that frustrates a lot of us who work here at Hayek, is we have a lot of great evidence that support what we do. And one of the reasons these patient events have come to surface is because we patients who want to talk about what we're doing, and we want to be transparent with the people that we interact with. But ignoring evidence, oftentimes you give studies to a provider, and they're like, well, these studies, they were all done in Greece. What does it matter? People in Greece don't need medicine. Like, what? But these things are disempowering scenarios. And as a patient or an advocate or an RT, we should push back on these disempowering encounters and say, no, I need you to read this literature, because I won't be dismissed in this instance. If we can have an intelligent conversation about why you don't like it, that's wonderful. Okay. In all things, we should be able to disagree peacefully and be able to say, okay, let's either agree to disagree or find some common ground if we can. Okay. Well, I have enjoyed giving this talk to you. Hopefully you guys have enjoyed it and I haven't bored you to tears. But we appreciate everything that our customers do for us. Really, people reach out to us with really nice interactions. We have wonderful physicians that we interact with on a daily basis. This is a very, very lovely place to work. And I'm blessed all the way around. I want to thank you for your time today. We always do question and answer, so please ask as many questions as you want. Take care.
All right, everyone. Thanks so much for sticking with us here. We really appreciate you staying with us. And please, we are preparing to get our question and answer going with the lovely Daniel Mergener and Coral O'Connor. Thank you so much. So if you do have any questions regarding the presentation, we'd love to hear them. Put them in the Q&A boxes on the top of the bar. But if not, please sit in on our conversation here. So take it away, Daniel.
Thank you, everyone, for joining us today. Coral, thank you so much for coming on board here with us.
My pleasure.
GC was very excited about his conversation with you, so we're very happy to have you on. How's the weather where you're at? Are you experiencing a little bit of rain and thunder?
Not right now, but I'm sure it will later.
All right, well,
This is Florida, of course.
well, yes, this is time of year.
Yep.
I'm going to go through some questions with you. Answer like how you feel like answering. I know you're not shy and kind of talking about how this has worked for you. Okay, so if you don't mind telling us a little bit more about yourself, we'd be happy to listen.
Sure. Well, the first thing I will tell everybody, before this all happened to me with my illnesses, I used to be an avid jogger, jogging about 10 miles, 4 to 5 times per week. I can't remember the last time I actually have been sick. And prior to moving to Miami, Florida, at first, I was diagnosed with asthma. And when I moved to Miami, I had never had an asthma attack since I moved to Miami in 1996. And when I first got my first doctor, he said that was probably the environment, the atmosphere that caused me not to have asthma attacks. So having it come back now, has been very interesting. But pretty much, um, I'm almost 60 years old. And like I said, was an avid jogger and exerciser throughout my entire life. I work for, don't know if you're familiar with the company, Ernst& Young, in Miami. And so I used to travel a lot and I was in business development. So that's pretty much my background. But as my brothers will tell you, all she did was jog.
Well, that
That's
means you had a
it.
good FRC. If you followed along with our training, you had a good
Yes.
functional digital capacity as a jogger.
I, yes, I
So,
am. And, I'm a fighter jet maniac. So I've got a lot of friends in the Air Force and know some Blue Angels. So those are my two things.
we like to
Flying
hear
and around, yeah, hanging around pilots and running.
that. Running and flying fighter jets.
Exactly.
Outstanding.
Yeah.
So tell us more. Tell us a little bit about. I mean, that's a great background, and
Yeah.
tell us a little bit about your condition and the challenges you've kind of faced,
Okay.
and managing it before BCV.
Yeah. Well, okay. So this is going to be, all this has happened to me very quickly. Um, and this started in 1922 when I was actually admitted to the hospital. And believe it or not, one of my coworkers, she used to be a nurse, and we were actually on a Teams call for work. And she saw me breathing very hard. And
Hmm.
she was a little concerned. She said, "Why do you sound so out of breath?" And I mentioned to her that I felt like that for a few days. Not to mention, I lost a lot of weight, a lot of weight. And then the other part, I noticed that I was walking very slowly, like I was barely moving. So everything just for me came on rather sudden. And it just so happened we were on the call and she heard me breathing, literally asked my mom to go and get a pulsometer to measure my oxygen. Um, Luckily for me, CVS pharmacy was downstairs in my building. So we went that, and when they read the oxygen back to her, she goes, "You got to go to the emergency room right now." And I go, of course, calmly, "Okay, I'll go tomorrow." So she puts her husband on, who's a respiratory therapist, believe it or not. And when he explained to me why I needed to go to emergency, and then he explained why my oxygen was that low, he explained what would happen. I go, okay. So from there, we called 911, got
Goodness.
to the
Okay.
hospital. And after they weighed me during that time, 3 months, I had like over 40 pounds weight loss. So it was pretty bad. And Daniel, after that, I don't remember what happened. Apparently, I lost consciousness.
Hmm.
And during all of that, not to take up too much time here, I was diagnosed with chronic respiratory failure with hypercapnia. Apparently, I have a high carbon dioxide level. So that needs to be managed on a daily basis. And during eh, whenever I was in intensive care, they noticed a lot of muscle twitching on my body or all over my body. And so that's when they thought it might be ALS related to and all of that. So that's the combination of the illnesses I've been diagnosed with is a respiratory failure with hypercapnia and an ALS.
Now,
So
Coral,
that's
when you were in the hospital, did you end up on a ventilator?
yes. So I don't know if my clinical sales specialist is on this call, Art Rodriguez. I hope he is, so he can correct me in anything I say. But apparently, my pulmonologist was the one who saw me on a BiPAP machine, and thought that I looked so uncomfortable. I don't like anything over my face. And so he saw me, and apparently it looked like I wasn't comfortable at all. And so Art was already at that hospital demonstrating the machine, and they got in contact. My pulmonologist reached out to him and said, let's try the BCV on me. And that's how it started. And apparently, what really convinced him was, um, after they put me on the respirator for like 2 hours or so, they did like took a blood test, and my
Mhm.
carbon dioxide was down, and that was the thing that convinced my pulmonologist right away, that this would be a good one. Not to mention making me feel comfortable with it. But
Sure.
yeah,
Now,
yes,
what has your experience been like with BCV? Because now you use it at home,
yes,
and it was able to help with the hypercapnia.
yes.
You use it at home. So tell me
I
about your
use,
experience at home with it.
well, I please don't call it the BCV. It's my nurse's aide named it Ricky. Don't discuss that. It has a name
AKA
now.
Ricky.
Yes, yes, it's Ricky. Um, the thing about it, so I have two other settings that they put on it, which is very helpful, was the continuous negative and the
Mhm.
cough assistance, the secretion clearance for me. So those are two additional things I do in the afternoon, when I'm okay to do it. So those are the settings. So I would tell you this. The first time I noticed the big difference is when I get up in the morning, because I sleep with it. When I get up in the morning, my chest feels so light, like it's not heavy at all. And when I get up to stand up, I'm not usually like hyperventilating like I usually do. So that was a big thing for me to have that big difference. The other thing is pretty much I'm I don't need like oxygen during the day. I mean, I take my oxygen, so I'm pretty like I'm here staying with my brother, and I pretty much get up with the machine, and I don't. I even though I'm moving around slowly, I move around slowly, but I am not hyperventilating or anything throughout the day, and so that is for me a big deal.
It's
So
amazing.
at least I can move around a bit. So yeah, but it's been actually that's why it's named Ricky. My aide said when she puts me on the machine,
Mhm.
about 10 minutes I'm out, like literally asleep. She
That's
said
amazing.
I just look so at ease. So the other thing I can tell you, and this is probably a good thing for you guys to know too, is that I mean, a few months ago, I was in the hospital. Our firefighters don't know about this machine. And I
Hmm.
have a lot of friends who are firefighters. It will be a good thing if you guys introduce them to this, because when paramedics come to pick me up and I go, please pick up that machine, they all looked at it like it's a foreign object. And when I
Please get Ricky.
explain and when I explain it, they go, okay. So that is I think that's a big deal. So I take that with me to the hospital, and that's what they use when I go to the hospital.
Good
So
for you. Good for you.
I don't use the BiPAP at all. I'm just not comfortable with the mask on my face.
No. And how would you explain your experience with the device, with the cough assisted cough portion, with the
Well,
high frequency? You use
I
those
only have
often?
yeah, I only have one thing to I have not gotten a serious cold at all, because I'm just very particular about where I go. The other day though, I got like a COVID asymptomatic condition that sent me to the hospital. But the one time I did ask Art, the cough secretion when I felt my chest getting congested, I went on it, and the next day my chest was clear. So I actually asked him, "Where does the cough go? Does it like escape into the ceiling?" Because I didn't get it
Hey,
in
Ricky
in
took
the
it.
morning. Ricky took it, right? So in the morning, my chest was clear. So that to me is so. Anytime I feel that potential of a congestion coming on, I immediately do the secretion clearance, start doing that more often, and that seemed to help. And if everyone wants to know, it's not painful or anything. The only thing is when they first and they saw my chest jumping, they were like, "What is that?"
Yeah.
But
What's going on with you? Yeah.
what's going on there? But it's very easy, and it depends on how many minutes you want to do it. But I make sure when I feel like I'm getting congested, I make sure to do more sessions of that.
Way to
So,
go. Good for you. Now, before you had used it, had you experienced that orthopnea, that shortness of breath when laying down? Was that an experience for you?
no, I mean,
Okay.
like I said, this came on pretty sudden.
Suddenly.
I don't, and this shortness of breath or whatever, because like I said, I jog for 10 miles almost every day. So, and I was never out of breath. So, this coming on for me was a big shocker to me and my family for this. And then to top it off, having ALS just came on pretty sudden. So before that, and like I mentioned, also I hadn't used an inhaler in almost what close to almost 28 years.
All
So,
right.
so that's the other part of it too.
So, what would you say to someone considering this? So, this is why we like to do these patient events, is to educate people from your perspective. So, what would you say to a
Well,
patient who's on the fence about this?
the first thing I will tell you this is, and it doesn't stop at all. You mentioned the tracheotomy. I never
Mhm.
want to have one of those. I
Mm-mm.
just it looks too uncomfortable. And the number one thing is, like I mentioned, I don't like things over my face. So even during the COVID, I made sure I stayed inside most of the time so that
Right.
I wouldn't have to put the mask and wear it on all day because I know that would actually start me breathing, having given me the breathing issues. So
Sure.
pretty much, I just say, how should I put it? I just feel better knowing have it on my chest than on my face, a mask on my face. At least, I sleep with the BCV for about 8 to 9 hours every day. So
Mhm.
having a mask on, a BiPAP on my, no,
No.
it's not gonna be, it's not gonna
We,
be
we,
comfortable to me at all.
we like the way you think. We can agree with you.
Yeah, yeah, yeah. The only thing I would do, I don't know if there are ALS patients on here. The only guidance I would give them is hopefully they have a really good caregiver that can actually put the machine on. Because for me, I don't have the strength to do it. But I'm the one who takes the machine off in the morning. So
Look at you.
I can actually take it off, but putting it on requires a great deal of strength to get the vest tight enough so that you don't get air seeping out. So that I have an aide do. But in the morning, I'm the one who actually puts it off, takes it off. So yeah,
Wonderful. Your story's inspiring. Your personality, like your attitude about this whole process,
yeah.
it's inspiring. And I'm hoping that people hear this and you become like, an invisible advocate for them, right? Because
Well,
they say, Coral can do it, right?
yeah, yes, and the other thing too is I just recently moved to Jacksonville from Miami, and so I have a upcoming appointment that I am getting in started with the ALS clinic here, and so I'm definitely bringing my brochures to them because I'm sure they probably never heard of it either, but I'm going to introduce them to because I will be candid. They at the ALS Center in Miami, they I see them every 3 months. Every time I go, they mention tracheotomy, and I go, "You forgot about my machine,"
You
you
forgot
know.
about
So
Ricky. Yeah.
yeah, so it's like it's not
Yeah.
that they've forgotten. It's just that I'll be candid here for the ALS clinic. That seems to be, at least in Miami anyway, that was the one. So I took the brochure over there, so just to get them familiar. This is this is how I use and this is how what I'm comfortable with.
Amazing.
So yeah,
Amazing.
yeah.
Well, is anything you want to say to this lovely crowd
Um,
before we part ways?
I would say, you know, it for me everything has been an adjustment. and a new way of life, not being able to do certain things, but I still am able to breathe as good as I possibly can. I may not be able to walk. I do use a walker. So can you imagine me walking like a mile and a half with my walker, getting back home and not being out of breath?
It's
Yes,
amazing.
that has happened. So
But
things, I may not be able to run as much as I can, but I can still, hopefully now go outside and enjoy the outside. So still being able to do certain things just keeps me, in a positive mood. So I have
You're an
Ricky to
inspiration.
thank. I have Ricky to thank for this. Only one question I do have for you guys.
Go
Anybody
ahead.
anybody planning on doing a remote or an app so that it's just easy to click the off button on the machine?
Oh, that's a
That
great suggestion. I don't think I've heard
that
that
would be
suggestion before.
yes. No, that would be perfect. If Because to be candid, and I only say this because of my experience in the building I used to live, our fire we have a lot of fake fire alarms, and so when
Mm,
I had to, get up, that machine when it's on your chest, that's with all the air going in, it weighs a little bit when you're trying to get up. So it would be nice if we just had something to click a button, or if there was an app where we could just press off. Because once
that's
you
an,
turn it off,
mm.
the air stops and you could just get up. So that would probably be the only thing I would ask if you do have.
That is an
That-
incredible suggestion. Actually, no one's ever,
yeah,
I don't think I've ever heard. So, I mean,
yeah.
we'll have to call it the Coral app if we use it, right?
Oh boy. Yeah. So that's probably be the only thing. And just to give other people advice too is, if you don't have ALS and you're pretty, strong, you can probably be the one to put the machine on, um, or even change the seal on the chest, the cuirass. But if you don't have that strength, don't try to do it. Because for me, combination of ALS and a respiratory illness, that gets me out of breath when I try. So that would be, try just do what you can, but don't overdo it.
That's great advice. Great
You need,
advice.
yeah, you need to have a professional or a caregiver around you to use it. Um, But if you do have that, look at it this way. At the very least, my caregivers, because I would get on the machine in the afternoon, we go out for a walk later in the evening. So
That's
it just look at it this way. Your life still continues if you have it. So that's my
an
suggestion.
inspiration.
Yeah.
Thank you. Well, thank you for introducing yourself to us and Ricky. We we appreciate your time today.
Yes.
It's been
Yes.
a blast. It's been a blast. Um,
Thank you.
you're a blessing. Please reach out to us. These ideas you have, if
Bye.
you get ideas, tell Art. Art's, he's
I
full of
was.
ideas. So
Yeah.
tell
Yeah.
tell tell him, he'll bring them back to us. But
Yes.
we appreciate your time today.
Yes.
And
Thank you
your
so very much.
energy, your enthusiasm. No, it's intoxicating. And
Thank you.
we're blessed to know you.
Thank you very
Good.
much. I'm glad to have you guys. That's for sure.
You get to hang
All
out with
right.
Art. He's fun.
Okay. Thank you. Thanks.
Thank you
All
very
right.
much, Coral.
All right. Take care.
All right. Thank you again, Coral. Thank you so much, everyone. We really appreciated you jumping in with us today. Always a pleasure. We'll be doing more events like this in the future, so keep an eye on your inboxes. And yeah, thank you for everyone who made this happen. Daniel, Andy, Stacy, monitoring the chat, everyone, and Coral especially. Thank you again. And I hope
Yes.
everyone has a wonderful day.
You
Thank you
too.
all.
Thank
Thanks,
you.
Coral.
Thank you. Which George? How do I check?